Please get started.
Okay. Good morning. Today we'll have a long case discussion. Dr. Sharup Shatra, who is from RKM Sharapadishta and Bhivanishwa Medical Sciences, will present the case. And with us today is Professor Saurabh Ghosh, who is Professor of Surgical Oncology at Calcutta Medical College. Will take a scenario. Saurabh, you can share your screen and present. Wait at the end of history. We have some discussion on history, and then in pass on to examination, and then further discussions. Okay.
Good morning, respected teachers. I am Saurabh Shatra from RKMSP VIMS, DNB General Surgery PGT.
Yeah.
Today I'll be presenting a case on a right iliac fossa mass. My patient, Mr. Mahato, a 60-year-old male, farmer by profession from Bankura, West Bengal, presented with chief complaints of generalized weakness for last 4 months, intermittent pain abdomen for 2 months, altered bowel habit for 2 months, and swelling in the right lower abdomen for last 1 month. Patient was apparently well 4 months back when he suddenly felt an easy fatigability at work 4 months back, though he can perform his daily activities normally. He had a history of loss of appetite for same duration. He used to take less than half the amount of food he used to take previously. He also has a history of unintentional weight loss for last few months, though it's not measured because the 4 months back the weight was not measured by him. The pain was associated. The history was associated with right lower abdominal pain, which was insidious in onset, dilating, intermittent, non-radiating, no any aggravating factors. So it used to get relieved by oral medications over the counter or by as prescribed by the quacks. He felt an approximately 5 into 5 centimeter, according to his gesture, swelling in the right lower abdomen for last 1 month, which was first felt while he was bathing. For last 1 month, he complained of altered bowel habit, on and off passing of loose stool. There was a history of passage of few episodes of foul smelling black tarry stool, which was soft in consistency and difficult to wash away. There was no history of fever, cough, swelling anywhere else in the body, or any metastatic symptoms like jaundice, back pain, hemoptysis, chest pain, headache, or dysuria or hematuria. The past history, there is no any major ailment or any surgical intervention in the past, except is hypertensive and on medication for last 10 years. No other known comorbidities, or no history of pulmonary tuberculosis or intake of ATD or in contact of TB. Is married, his spouse is alive and has 2 children, both are healthy. He belongs to a low socioeconomic class and takes a normal mixed Bengali diet. His sleep and bladder habits are normal, though his appetite is decreased and has altered bowel habits for last few months. He is a regular smoker of bidi for last 40 years, no history of any alcohol intake. And in the family history, his parent had both parents died naturally. His 2 younger siblings, he has 1 brother and 1 sister. They don't have any similar disease. There is no family history of any cancer. There is no known allergy to any food or drug. And in treatment history, there is a history of frequent analgesic intake for last 1 and 5 months as prescribed by the quack or over the counter. Patient is on medication by the quack for generalized weakness for last 4 months. Now summarizing the history, the 60-year-old gentleman presented with generalized weakness for last 4 months and dilating intermittent pain in right lower abdomen for last 2 months associated with passage of loose stool, and a few episodes of melena and a lump in the right lower abdomen since last month with unintentional weight loss and without any associated history of fever.
So at this point, you have concluded the history. Sir said we want some discussion on it. So what are your thoughts at this point?
Sir, as the patient is old enough, that's elderly, 60-year-old, with generalized, presenting with generalized weakness and a mass in the right lower abdomen, specifically in the right iliac fossa. Being in a country like India, just first we'll think of ileocecal TB or
Mhm.
as he has history of history of unintentional weight loss, we can think of some carcinoma in the right colonic areas.
Okay, fair enough. Anything else that could be? It could be.
Yes, sir. Yes, sir. There are some other possibilities also, like some other tumors or in the right iliac fossa, like lymphoma. It can be,
Mhm.
or there may be some uncommon pathologies, like some appendiceal carcinomas. It may also be
Okay.
possible.
But
Or
so they are all malignancy. Basically, in an elderly
yes.
man with significant weight loss, loss of appetite, asthenia, and if you take into account the passage of black stool along
Yes,
with
sir.
a lump, this is a very,
Yes,
very
sir.
classical presentation. So you can't really have too much of differential diagnosis. Without the lump, if there was no lump, you could have thought of some other things. But a lump in the right lower abdomen, along with these things, you have to think of some sort of a malignancy related to the GI tract. Okay,
Yes, sir.
carry on.
Okay, and hey, there are some points in history to discuss. Go back to your history present illness.
Sir.
You see, you have described just one line. You see, patient having symptom for 4 months. These
Yes, sir.
fatigability, loss of appetite, these are usually progressive in patient who has got underlying malignant disease. So you have just mentioned this duration. One should also describe whether this is progressive or not. Okay.
Okay, sir.
And second
Yes, sir.
is, you said bowel habit. Come to the point in the bowel habit. You
Yes,
see,
sir.
you cannot just describe bowel habit alteration by passes.
So you are muted.
To describe what was the habit before the illness started. Number one, maybe
Yes, sir.
that you are passing stool once or twice a day, and then what happened over last 4 months. So give a good description of his bowel habit. Just not saying he is passing stool on and off. That is not equivalent to altered bowel habit. Altered bowel habit is one where you give a description that patient usual bowel habit before the illness started was he was passing stool once or twice a day, and over the period of last 2-3 months he's noticing that he has to go to the toilet number of times. That is maybe increased frequency of bowel movement, or if it is a left colonic carcinoma, it can be has got increasing constipation. So that is how you describe the bowel habit. Okay, so this
Okay, sir.
part has to be taken care of. You describe the progress of the symptoms. Somebody has
Okay,
a loss of weight, it will not be significant weight loss at the beginning. You see, loss of weight can be started. He feels that he is feeling weak, and then at the end of this period of time, he's noticing that this is increasing, and then he is aware that he has weight loss. So it's just not the weight, because you are saying the chief complaint in again history of illness, same line. We want some elaboration of the symptoms, and
okay,
as
sir.
you started in an elderly patient like this, with this classic features, I will not put tuberculosis as first diagnosis even in India. Okay, in this patient,
Okay,
the
sir.
first probable diagnosis should be malignancy. You can put
Okay, sir.
tuberculosis in the next part, but if you see the classic presentation you have created, this is classic of malignancy. Dr. Ghosh, what do you feel? Should we say
Yes, sir.
tuberculosis?
Yes, yes. Maybe better to say malignancy first, but also tuberculosis. Okay, since I am asking him for possibilities, it is
Yeah.
okay if he also includes COX. COX is
Yes.
also associated
What
with
I'm saying is,
weight loss
first
and
thing
loss of
should be,
appetite.
yeah.
Fair enough. Malignancy first. I take your point, sir. And
Okay.
your point about the elaboration of the progress of symptoms is also very important.
Okay, carry on.
Carry on.
Come to examination part.
I have examined my patient in a well-lit room with informed consent and adequate exposure. Patient lying comfortably in the bed. Patient is conscious, alert, cooperative, and is well-oriented to time, place, and person. And his Colonoscopy scale is 80 and ECOG 1. So his build is average. Patient is nutritionally malnourished, and no other significant changes in the general survey. Pallor is present. Icterus, cyanosis, clubbing, edema, or dehydration are absent. As pulse rate is 86 per minute in right radial artery. It's regular, high volume. Blood pressure is 130/80. Is on medication. Respiratory rate is in 80 per minute, and temperature is not raised. On abdominal examination, the shape of the abdomen is normal. Umbilicus is midline, inverted, and central. Flanks are not full. All the quadrants of the abdomen are moving proportionately with respiration. There is no scar, pigmentation, venous engorgement, or pulsatile movements. No visible peristalsis or lump. Hernial sites are normal. External genitalia are within normal limit. There is no flexion deformity at hip joint. On palpation, on superficial palpation, the temperature is normal in all the quadrants, equal in all the quadrants. No tenderness in the right iliac fossa. Abdomen is soft. On deep palpation, a mass is palpated in the right iliac fossa with of size 5 into 5 centimeter approximately, globular in shape with well-defined margins. Surface feels smooth with firm consistency and restricted mobility. On straight leg raising test, the lump becomes less prominent. Skin over the lump is normal. Liver spleen not palpable. Kidney not bimanually palpable or ballotable. No other lump or mass palpable. On percussion, the percussion over the mass is dull. Shifting dullness is absent. Liver span is approximately 11 centimeter in the right midclavicular line, starting from 5th intercostal space. Splenic dullness absent. Normal tympanic node in the rest of the abdomen. On auscultation, normal bowel sounds are heard. On per rectal examination, the fecal stain present in blood, no blood pinch, normal anal tone, no growth of pelvic deposits felt. Prostate is grade 1. And systemic examinations, they are essentially normal. The cardiovascular, respiratory, and neurological systems are essentially normal. Now let's summarize the. In summary, the 60-year-old gentleman presented with generalized weakness for last 4 months and dilating intermittent pain in right lower abdomen for last 2 months, associated with passage of loose stool with few episodes of melena and a lump in the right lower abdomen since last month with unintentional weight loss and without any associated history of fever. On examination, patient is anemic with an intra-abdominal 5 into 5 centimeter non-tender, smooth, well-defined, firm, globular mass with restricted mobility, palpable on right iliac fossa with no free fluid, no organomegaly, and DRE proctoscopy being normal.
So what's your provisional diagnosis?
Sir, by provisional diagnosis, it's a case of mass in the right iliac fossa in a 60-year-old patient, old gentleman, most probably of malignant etiology, likely to be carcinoma cecum without any evidence of distant metastasis.
Okay, so the patient also has anemia. That's not just mass. Anemia. You said the patient has pallor.
Yes, sir. Yes.
So what are the investigations that you will do to confirm your diagnosis or to arrive at some sort of a diagnosis in this case?
Before that, Saurabh, as you said, the lump is 5 centimeter. So if you say 5 centimeter lump, I will not pass it because patient is in front of us. I will not pass that right iliac fossa looks normal as in the left iliac fossa. 5 centimeter mass is a mass which should show some fullness in the iliac fossa. You got my point? Because we are doing virtual classes. Once the patient is in front of you, and if you can find that there is a fullness and you miss that in exam, examiner is going to catch you. That you see that basically in final exam, clinical part counts. So clinically, you should be very conversant that you are looking at the patient and then there is no fullness at all. It may not be a swelling is seen from outside, but there might be some fullness in the two iliac fossa will not be same. And you said splenic dullness is absent. Means what? Why do you say splenic dullness is absent in this patient?
So there is no splenomegaly. That's what.
That is not splenic dullness absent. Normal spleen has got a area of dullness, 8 to 10 space.
Yes.
Splenomegaly is not described by absence of splenic dullness. You got my point?
Yes, sir.
Absence of splenic dullness may happen when there is distension of the large gut. If you have a distal obstruction and the gut get distended, it can override the spleen.
Okay, sir.
Splenomegaly is not described by saying splenic dullness absent. That is not a wrong statement. Okay.
Okay, yes.
How will you proceed with this patient?
Yeah. So at first, as an extension of my clinical examination, I'll go for USG to confirm a few points about the mass which is palpable in the right iliac fossa, just like the organ of origin of the mass and its attachment, if there is any attachment to the adjacent organs or any other swelling or nodes visible in USG or any ascites present or not. then after that, I'll go for the confirmation of my.
Something more with ultrasonography. Not only, it does not end there. Ultrasound does not end only with the mass. Something else can be also seen with ultrasonography.
So lymph nodes.
Many
Yes,
things can be seen. You are ordering an ultrasonography of the whole abdomen, isn't it? You will not write
Yes, sir.
ultrasonography of mass. You will generally
Yes,
say
sir.
ultrasonography whole abdomen. So what are the other things
Yes,
that
sir.
also ultrasound will tell you preliminarily? Corroboration of other clinical findings. Sometimes the liver may contain
Yes, sir.
something. The peritoneum may contain something.
Yes, sir. Many secondary deposits or say secondary
Yes.
that liver mates.
Ultrasound is a very good investigation, just action, clinical examination, but ultrasound is a very good investigation for intra-abdominal mass. It may not give you exact, you said relation of the mass to the adjacent structure. That ultrasound may not give, because ultrasound is not a good investigation of gut-related mass because of the gas interface.
Yes.
Okay, it can show you the mass, but cannot give you the exact delineation of the whole mass if it is a gut-related mass. But other things are very important. Ascites,
Yes, sir.
lymph nodes, liver, okay, other organs.
Yes,
okay, so these are all important.
yes. Okay. And then to confirm my diagnosis, which is suspected, I'll go for a long colonoscopy.
Full length, flexible full length colonoscopy.
Flexible full length colonoscopy, which will give direct visualization of the lesion.
Do you know the length of a full colonoscope, normal colonoscope? Do you have any idea?
It's a full length 160 centimeters.
Good. Carry on.
And it will also help us to take any biopsy if needed, or any synchronous lesion if present there or not, if there are any polyps present or not.
Okay.
And it will not give us any added advantage if the mass is extraluminal or.
What else you can see in colonoscopy? You said polyps. You said
synchronous lesion, polyps.
Yes.
Direct visualization of the
Anything
mass,
else?
biopsy.
Which can a lesion in the colon, which may be a predisposing factor for carcinoma. One is polyp. What other disease in the colon can be seen in colonoscopy, which can be a
the Crohn's disease.
Inflammatory bowel disease. Say inflammatory bowel disease.
Inflammatory bowel disease.
Yes. So that also you can pick up.
Yes.
What are the inflammatory bowel diseases?
So ulcerative colitis and Crohn's disease.
Which is more commonly affected in the colon?
So in colon, ulcerative colitis is most common.
So suppose you pick up ulcerative colitis and nothing else. What is the next protocol regarding colonoscopy? Check colonoscopy.
Sir, exactly, I don't know what I will take. Go for a biopsy.
From suspicious areas, yes, you can do. Suppose the biopsy shows some amount of dysplasia, mild dysplasia, then what?
Genetic testing.
Genetic testing for what? In a patient of ulcerative colitis, proven ulcerative colitis?
There is no mass, only ulcerative colitis. Try to understand, Swarup. The scenario is only ulcerative colitis. Do not find a mass. Mass with ulcerative colitis, again, you will proceed like malignancy with ulcerative mind. Dr. Ghosh is saying, you find ulcerative colitis. And then what next? This patient needs surveillance.
Yes.
This patient will need treatment and surveillance.
So if he is symptomatic, I'll go for the treatment. If he is asymptomatic, then just will repeat colonoscopy.
So what is the primary line of treatment? It is medical management or surgical management?
It's a medical management.
When will you consider surgery in ulcerative colitis?
So in case of any acute emergency first, or if the medical management fails after treatment of 6 months.
Any other specific findings on the background of ulcerative colitis that you feel that yes, the time has come for surgical treatment? What can happen in the colon in the later stages?
It's a perforation.
No,
are we worried about perforation? Perforation will occur if it occurs. Then the patient will come to you. If there is a colonic perforation, patient will come.
Stricture.
Malignancy we are talking about. What are
malignancy,
the
long-standing.
which patient of ulcerative colitis is more predisposed to malignancy? Suppose you get one colonoscopic finding that the left colon is involved, and another colonoscopic finding where the entire colon is involved.
Sir, pancolitis. If the patient is having pancolitis,
so if
then
there is pancolitis, there is more risk. Anything else?
More risk. If the patient is more than 60 years of age, 50 years of age, then
age, long duration.
So
long duration. Age has nothing to do with it. If the patient starts having symptoms at 16 or 18 and he is 40, even then he is at high risk. More than 20 years.
Yes. And in the right side of the colon?
Pancolonic means right side is also involved. So early onset, long duration and pancolonic involvement. These are all high risk factors for development of malignancy. In this case, even if malignancy has not developed, you can counsel the patient for a prophylactic surgery.
And another thing is, if you have extensive pseudopolyp formation, if there is formation of pseudopolyp, that is also a situation that this patient is unlikely to respond to medical treatment. So pseudopolyp again is a stage when the patient has disease for long duration.
You have to consider surgery.
Yeah. Okay, fine. So it's a mass, and you got a diagnosis of well-differentiated adenocarcinoma, and it's in the right colon. What next?
So then I'll go for the staging of the disease.
What are the staging investigations for a patient having carcinoma colon?
I'll go for CCT whole abdomen, sir.
Just CCT whole abdomen? That is not correct.
Sir, markers.
No. Markers will not stage the disease.
Okay.
Standard workup for a
patient having whole abdomen. You have to include thorax also.
Yes.
Oh, sir. CCT whole abdomen along with CT thorax and pelvis.
Whole abdomen and pelvis. You say
abdomen and pelvis.
CT abdomen, that is the pelvis, but better you say specifically CT abdomen and pelvis and CT
thorax.
CCT thorax. Yes, that is a recommended staging investigation for a carcinoma colon.
Yes, sir.
What do you see? What do you like to see and say yes? These are stage.
Sir, we'll see the tumor invasion, that is T, and the nodal status, that is N status, and if any distant metastasis is present, that is M status. This TNM. So we will go for TNM staging, and in TNM staging. So should we see the TNM staging?
No need. You know that. Tell me what is T4.
Sir, T4 is when it crosses the serosa and to the adjacent organs.
Just crossing serosa will not do.
A and T4A and B are there.
Okay.
And invading the adjacent organs.
Okay. Suppose
and what is N2?
Sir, N2 is 4 to 6, more than 6 lymph nodes. More than 4 lymph nodes, sir.
More than 4 or more?
More than 4 or more.
4 or more.
4 or more. 2A is 4 to 6.
N2A and N2B
is more than 6.
Yes.
Can you tell me what are the stations of lymph nodes in colon?
Yes, sir. There are epicolic, that is epicolic lymph nodes present in the wall of the colon. Then the paracolic lymph nodes, which are present in the arterial arcuate, and the fat present in the arterial arcuate and the colonic wall. Then I will go for the intermediate lymph nodes, that is according the arteries supplying the colon. Then the principal lymph nodes, which are along the principal arteries, like SMA.
No, I didn't understand. Then what is the difference between intermediate and central principal?
Sorry,
intermediate are also along the arteries.
Then paraortic, sir, principal nodes.
No, paraortic is retroperitoneal. Principal are at the origin of the vessels. The intermediate are along the course of the vessel. You understand? The vessels take origin from the aorta and they course for several centimeters till they reach the colon. So in between these, there are nodes lying along the vessels. Those are the intermediate nodes. But when you come to the origin of the vessels, those nodes are the central or the principal group of nodes.
And including the supermesenteric node for the right colon.
Yep.
Yes.
So these are the nodes according to the anatomical location. And the staging is, you have already said, N1, N2 based on number. So irrespective of the site, it is the number which decides the N1 or N2 or N0 status. Okay. How many nodes should be sampled in a? Oh, that's a. We'll come to that later. Forget about it. Carry. What other investigations?
After completion of the staging, just will prepare the patient for the operation. So
No other investigation. General investigations.
yeah, that,
Suppose this patient presented you with all the symptoms, but except the mass.
And here CA should come. In chronic carcinoma, as baseline, it should be a CA also.
CA and CA 99.
But even if you don't do CA 19.9, at least CEA you have to do. You definitely have to do CA. It's a soft prognostic factor also. It's I think it's a class 2 prognostic factor. American College of Pathology, College of American Pathology. So it has some prognostic value. It has some diagnostic value.
Yes.
Won't you do a CBC?
Yes, sir. For that, preparing it for the operation, we just go for the pre-anesthetic checkups and all those investigations.
So what will you get in the
preparing
CBC?
The patient for operation?
You have not mentioned LFT. LFT is very important for chronic carcinomas. Why?
Sir, because if there is liver mets, even the liver is not in the liver mets is not that much.
Do you think
get alkaline phosphatase change?
Do you think single liver mets will alter the LFT?
No, sir. LFT is important. Another in another way also, that for the albumin, sir.
Yes.
The patient's albumin is serum protein
are very important.
Yes, sir.
You have said that the patient has loss of appetite, weight loss significant for the last 4 months. So there is a high chance that the patient may be nutritionally depleted. In that case, you have to take certain initiate some measures. So these investigations you have to do early. So what will you get in the CBC? What is the picture that you will get?
In CBC, we'll get first is the hemoglobin level will be low, and there may be some changes in MCH and
what changes? What is that described as clinically?
It's iron deficiency anemia.
Yes.
How will you will know it as iron deficiency anemia on the CBC? What will you get on the CBC?
It will be microcytic.
Hypochromic anemia.
Hypochromic anemia.
You don't get iron deficiency on a CBC. You get microcytic hypochromic. So that will be reflected in the MCV, MCH, MCHC. All these values will be low. So what are the causes of microcytic hypochromic anemia?
Why patient has anemia?
Recurrent blood loss.
Colon.
Recurrent blood
loss and
so iron
also
deficiency anemia is one cause.
And
iron deficiency. What else? You are focusing on carcinoma colon, but examiner will take you in another direction.
So micronutrient absorption and deficiency of micronutrient.
Which micro? No, vitamin B12 deficiency will cause megaloblastic, not microcytic. What is the next important cause? One is iron deficiency. Other is?
So nutrition.
No, nutrition either through iron or through something else. It cannot be both. Thalassemia, Baba, thalassemia. Thalassemia also causes microcytic hypochromic anemia. Okay. So how will you distinguish the microcytic hypochromic anemia of iron deficiency from the microcytic hypochromic anemia of thalassemia? Thalassemia is also very common in our state.
Say age of the patients.
Age? Why? Minor thalassemia trait, a 40-year-old man. How will it help you? How will age help you?
Say
from distinguishing from. If he's an 8-year-old boy, then obviously you're not considering CA colon, no? Suppose he's a 40-year-old man. And suppose I have not even given you the age of the patient. I have just given you the smear, and smear is microcytic hypochromic. The two important causes are thalassemia and iron deficiency. What next?
Yes, sir.
How to stamp that it is iron deficiency? How to stamp that it is due to blood loss? You will get patients like that. Patients just coming with blood loss, severe anemia. Anemia, anorexia, no lump, no definite history of melena. Patient does not know. You have to prove that it is due to blood loss somewhere. What next? How to prove iron deficiency in the body? What test?
So occult blood,
Serum ferritin level,
serum
TIGG,
ferritin.
you have
Serum
not
ferritin.
heard of these?
Yes, sir.
Okay, carry on, carry
Yes,
on.
sir.
Okay, Shaurabh, you said albumin
Yes,
is
sir.
low.
Hmm.
How
Yes,
the
sir.
patient is admitted for surgery? How are you going to address this low albumin issue?
Sir, if it is not an emergency, we'll start on.
Patient is a lump abdomen, carcinoma colon is diagnosed, he is admitted. You want to discharge home with iron tablet?
No, not iron tablet, sir. It's
Then how going to
we'll give her TPN or just
very good. Don't say albumin.
TPN.
Yes, sir.
Sir, again you are muted, sir.
It's taking orally. The answer should be only albumin transfusion is not the answer in this situation. Okay,
Yes,
got
sir.
my point.
Yes, sir.
Sir,
Only
I'm not sure he has got your point. Why not albumin? Albumin is low. Give him albumin, Dr. Shaurabh.
Sir, if we transfuse infusion albumin, there it stays in the blood for only for 12 hours and it doesn't permanently increases.
So I will
albumin
transfuse the
level.
next day. Again, I will transfuse. Every day I will transfuse. 5 days I will transfuse. By that time, my anastomosis will have healed. There are many senior surgeons in this state who do that and who are still doing that, in spite of the efforts of Dr. Shah. So, sir, he is also not convinced. He is happy to give albumin for 5 days.
No,
But that
no,
is
sir.
another lesson, I think. We cannot cover parenteral nutrition and nutrition in this. Carry on. You don't give albumin, as sir said. Just remember that for the time being and go home and study. Albumin is not the solution to malnutrition.
so albumin low indicates global nutritional deficiency. So it's a state of malnutrition. You should try to build up the patient as a whole nutritionally, not only giving albumin. Okay, so that is the answer.
Yes.
Okay, next.
Not only not giving albumin, don't give albumin. Please don't give albumin. It's a waste of money.
Yeah. Okay, fine.
So now
The patient has got a optimal albumin.
it is a CT3 lesion, T3N1.
Yes.
Yes, sir.
And a T4B&3. What next? N2.
Sir, for T3N1 lesion, we'll go for radical right hemicolectomy.
Radical right hemicolectomy. That's right. Fine, radical right hemicolectomy. So what is the difference between your radical right hemicolectomy as compared to a simple right hemicolectomy for, say, hyperplastic ileocecal Cox or ulcerative colitis?
Sir, radical right hemicolectomy includes the removal of the lymph nodes along with the
before lymph nodes. What else?
Which lymph nodes? Which lymph nodes?
It's now described as total mesocolic
excision.
Okay, so it's not only the gut you are removing.
With CVL. What is CVL? Hello, Dr. Shaurabh?
Yeah.
Sir, I don't know, sir.
Central vascular ligation. So you have to go right up to the origin of the main feeding vessel of that particular area of the colon and ligate it there. That is the way you will ensure that complete mesocolic excision is being done. So what is your preferred approach to this surgery?
Sir, artery first, that is turnbull approach.
No, I'm talking about the access, open or minimal access.
Lateral to medial. Now this is well-established technique of doing colectomy. What is medial to lateral? What is lateral to medial?
No, first of all, open or minimal access? You tell me that.
Yeah.
Sir, according to the expertise,
you have dedicated laparoscopic surgery in your hospital.
Then laparoscopy approach, sir, medial to lateral.
Why? What is the advantage over open?
Is there any advantage over open, or is it disadvantageous?
Advantage of laparoscopy over open.
So advantage of laparoscopy over open is less blood loss and
Get blood loss.
post-operative pain is less.
Okay, but here this is not lab coli. This we are doing for a cancer. So oncological outcomes are also important. So does the less post-operative pain make up for loss of oncological outcome?
No, sir.
Would you be happy to accept less post-operative pain only to have an earlier recurrence of the disease?
There are a lot of points. You have to defend it. You have to defend it, Dr. Ghosh, that yes, laparoscopy is also feasible, and just say us the points.
Is it oncologically safe?
What the publication says.
And which publication?
Sir.
So this you have to know. If you say laparoscopic, these are the things you have to quote.
And so nowadays he has to say laparoscopy in colon. He has to say laparoscopy. You cannot say, even if it is not done in your institute, in your MS discussion, you have to say that laparoscopy is the preferred means of approach.
Because you see, if you see the recent publications, the outcome, the extent of resection, lymph node harvest, everything is comparable.
Same, comparable in both open versus laparoscopy.
Yeah. So, but you can
mention one or two trials, cost trial, color trial. You have to mention one or two trials by name.
This question are asked in RRC. What is Turnbull's technique in colonic resection?
The Turnbull's technique is in where we ligate the vessels first, then we'll go for
Good. No touch technique. So you don't go to the tumor directly. Normally we would get hold of the colon and start dividing the, what is the lateral line along which we divide on the lateral paracolic gutter?
Line of Toll.
Good, white line of Toll. But Turnbull's technique says don't go to the colon, don't touch the colon. Directly come to the root of the mesentery, identify the vessels and ligate them first.
Yeah.
What is fascia of Toll? You said line of Toll. What is Toll's fascia? Do you know?
It's a name I can remember, just I can't remember it.
It is the connective tissue adhering the mesocolon or separating the mesocolic layer from the retroperitoneal fascia. So you have to go along the Toll's fascia when you are doing the dissection, whether open or laparoscopy. But it is particularly important in laparoscopic because the gonadal vessels, the ureter, they lie below the Toll's fascia. You have to stay in the Toll's fascia. Okay, to avoid injury. What is IRETA? IRETA? Have you heard of IRETA? IRETA method of doing laparoscopic right hemicolectomy. This is the right colony growth, no? Initial retrocolic endoscopic tunnel approach. So suppose you are doing right hemicolectomy laparoscopically. What are the port positions? You have any idea?
No, sir.
I think in the surgery exam, you should be discussing surgery, not adjuvant therapy and chemotherapy. You should have more interest in biology than chemistry. So I always try to ask about surgical things.
Yeah. Where are the ports? You need to operate on the right side mainly, and also you have to go some part towards the midline. Have you seen?
Sir. No, sir.
What port, what size? So these things you have to know. You may not have seen. That is fine, but at least you should be able to say something. Maybe in your institute, they are not doing laparoscopic right hemicolectomy. We also do very rarely. Maybe once in 2 years, we try once. We are also beginners. But there are many institutes in our state also who are doing regularly. So now you cannot say, today's world, you cannot say, I don't know. You have to say something about laparoscopy. So port position,
attend workshop. This was done in last Sasikon. Dr. Rai Patankar has done a very good right hemicolectomy.
Exactly. So this is being done regularly in Kolkata. You don't have to wait for the workshop. It is regularly done in Kolkata in some centers.
So basically, you operate mainly with the left-sided ports. You have a supra or subumbilical port for the camera.
That is a 10 mm port.
Have a triangulation, one port in the left spinoumbilical line, and one port in the upper side towards the
around a hand's breadth. Hand's breadth above that in the left middle or upper quadrant.
Yeah, and then you have a port in the right.
And there will be another port in the right lower quadrant for retraction of the bowel.
Yeah,
that is also a 5 mm port.
Yeah.
Okay. And the right upper quadrant port, you would generally keep a 10 mm port because you will have to introduce the stapler or the clip, the Himola clip applicator, which is a
12
10 mm.
12 millimeter. If you use a stapler. So, what structures you remove in the right hemicolectomy? You are trying to say that. What are the extent of resection? Proximal, distal?
Proximal will resect the 10 to 20 centimeter of the ileum.
10 to 20 is very good. Don't say one thing.
Area. 20 is too much.
So why do you not want to remove too much of ileum? Distal ileum? Is the terminal ileum different from the rest of the small bowel?
Yes, sir.
You see, if we are talking of a standard right hemicolectomy, it is 10 centimeter ileum. If you say cecal growth, you can take up to 15 centimeter. That is an acceptable limit of small gut dissection. 20 centimeter is not required.
Dr. Swarup, why not? I mean, why do we want to preserve terminal ileum?
Sir,
Terminal ileum is a site for number of important function, like?
Yes, sir, vitamin B12 absorption and
then?
And bypass. Enterohepatic circulation occurs to the terminal ileum.
Yes.
So you should not remove it unnecessarily. So if it is a ascending colon growth, 10 centimeters is enough. Like sir said, if it is a cecal growth, then you need to take a little more. But try to preserve terminal ileum. Don't sacrifice it needlessly. Okay.
Distal, how much?
So distal proximal 1/3 of the transverse colon, sir.
What are the vessels you ligate while doing right hemicolectomy? What are the vessels you need to ligate?
The vessels will ligate our ileocolic artery or ileocolic vessel, and then in some cases right colic is separately, it arises separately, so right colic will be ligated and the right branch of the middle colic.
Yeah. Okay.
So what are the predisposing factors for colonic cancer?
So there are several factors which affect, which causes the colonic cancer or marked as a precancerous for the colonic cancer, like the FAP, familial adenomatous polyposis, HNPCC, then Peutz-Jeghers syndrome.
4 or 5 sentences about familial adenomatous polyposis coli. 4 or 5 sentences important. Short note.
Familial adenomatous polyposis is occur due to APC gene mutation.
On chromosome
5.
Good.
5.
Then transmission.
Autosomal dominance.
Good.
Acha. Then presentation, penetration.
How many polyps?
Variable penetration.
Sorry, sir.
Usual number of
penetration of the gene, the expression of the gene. Suppose I have APC gene mutation. Is it likely that I will get the disease? Definitely. Like if you have BRCA1 mutation in breast, not everyone will get CA breast. 80% will get CA breast. So similarly with APC,
penetrance is, say APC, this one penetration is 100%.
Almost 100%. So say that.
100%.
Achha, sir, ask how many polyps? How many polyps? There is a non-polyposis colon cancer syndrome also. You know that?
Yes, sir. Yes, sir.
So how many polyps do you need to call it?
More than 100.
More than 100. More than 100.
More than 100.
Is it possible to have less than 100 and still have FAP?
Yes, sir.
What is that?
Called attenuated FAP.
Attenuated FAP.
Yes.
Is it possible to have polyps in non-polyposis colon cancer?
Yes, sir. There's possibilities of to have polyps in non-polyposis colon cancer also.
Also, but it will be generally less than 100. So just because there are polyps doesn't exclude the diagnosis of Lynch. Okay. So even in Lynch syndrome, you can have polyps.
Polyps, yes.
What is the transmission of Lynch? Transmission.
So 30%.
Lynch. Hello.
Say
hello.
Exactly, I can remember. Hello.
Autosomal dominant, Baba. Yes, audible. Autosomal dominant. That is also autosomal dominant. Achha, what are the other predisposing factors? Quickly, we are running out of time.
The Peutz-Jeghers syndrome, sir.
Okay, very low risk. Tell me some acquired factors. These are non-modifiable, no? These are all genetic factors. Tell me some environmental or acquired factors.
Yes, sir. So modifiable among the modifiable factors are smoking, alcohol, diabetes,
What
and
about diet?
obesity.
What
So
about
diets
diet?
are yes, a high intake of processed food, high animal protein diet, fat diet, low
Alcohol.
amount of fiber diet,
Yep.
smoking, alcohol.
So high fiber diet with lots of vegetables and fruits is protective, supposed to be protective. Any role
Yes,
of previous appendicectomy, previous cholecystectomy?
yes, sir. Previous cholecystectomy increases the risk of
Very
colon cancer because
okay. So
appendicectomy also.
Any role for aspirin? Any role for aspirin?
Chemo prevention. Have you heard of the concept of chemo prevention?
No, sir.
People are saying that in high risk cases, sometimes aspirin can be preventive.
Calcium supplements, aspirin, vitamin D, many things have been tried. Some of the trials have shown favorable results. Veteran study.
One question regarding surgery. Once you explore, when do you decide the growth is not resectable? Because you have a CT impression and you gone in for resection. Now you find a situation. When do you say it's a non-resectable growth? For a CTM?
It's if there's peritoneal deposits present.
Okay, agreed. Definitely. Then maybe you, if the extensive peritoneal deposit, you can excise. You can excise.
I said non-resectable. I'm not saying curative resection. I'm saying the growth is not resectable. When?
In modern era,
you can remove everything. You cannot remove everything. You see, if the growth is invading to the retroperitoneum and its growth is fixed, there is no point cutting through the tumor tissue. Okay. If the growth is adherent to the gonadal vessels, you can sacrifice the gonadal vessels. Okay. So
yes.
a fixed mass.
You can sacrifice the kidney and the ureter.
Yeah. But if it is
extensive retroperitoneal involvement, I would agree with sir. Yes, extensive retroperitoneal involvement is probably a contraindication.
Yeah. You have done surgery. How do you follow this patient up? Patient has gone for adjuvant. Adjuvant is done. We are not discussing the adjuvant treatment. What is the follow-up protocol for patient having carcinoma colon?
Yes, for follow-up of patient of carcinoma colon, just we'll go for CA every 3 to 4 months.
No. What is the frequency of follow-up? First is frequency. How frequently you like to see the patient?
To say the same thing, if you are doing the test, you will see it.
Yes, sir.
So you will ask the patient to come back at that time.
3 monthly first. Then
for the first 2 years, yes.
First 2 years.
3 monthly, then 4 monthly, and then 6 monthly till 5 years.
Yes.
And with imaging and CEA. At least every 3 to 6 monthly, in many centers, they will do a CT scan of the abdomen and thorax. And also do a CEA. At 1 year, you will do a check colonoscopy. What are you looking for colonoscopy?
Sir, every year we'll do colonoscopy for any metachronous lesions.
Directly, you will not get a metachronous lesion. More commonly, you will get a predisposing lesion. What is that? Polyp. Another polyp can come up. Adenoma carcinoma sequence in colon is well established. So you may get another adenoma, which is not familial or syndromic. You can just have polyps without having familiar adenomatous polyposis coli. Just adenoma, simple adenomas. What is a polyp? Can you tell me what is a polyp? Simple questions you are.
What is a polyp?
Difficult questions you are answering.
Polyp is what? Something totally.
You know what it is, but you have to define it.
What is that?
You know, but define it. It's a focal elevation of the mucosa containing a fibrovascular core. It may be sessile, it may be pedunculated. Focal elevation of mucosa or even skin, epithelium, with a fibrovascular core is a polyp. Okay.
Okay,
Hello.
you have sent the specimen to the pathologist. What are the important things you like to know?
They will abroad.
But I think we have lost Charu. Oh no, he is there.
Sir,
Pathology report.
sir, first is the margins, the nodal nodes, number of nodes.
Don't margin say node mat jao. Stick to the tumor. You said margins means proximal distal margin. What else in the tumor itself?
Sir, investments for the teeth, those.
Huh?
Sir, investments.
Differentiation is the next part. What type of carcinoma it is, and then well differentiated, moderate differentiated, poorly differentiated. These are important. What else? They also comment on perineural and invasion. These are all very important for prognostication.
Okay, sir.
Okay.
How about the total number of lymph nodes? How many lymph nodes you need for adequate staging?
Sir, 14.
Someone needs to mute.
How many lymph nodes you should remove in a standard hemicolectomy?
Sir, 14. Sir.
12.
More than 12. 12, at least 12.
That's 12. And what?
When will you advise adjuvant therapy?
Genetic analysis tumor itself?
Sorry, sir.
When will you advise adjuvant therapy? After resection?
Oh, after resection, if it is stage 2 and there are less than 12 lymph node clearance.
No, I'm talking of
So if it is a T3,
further assessment of the tumor itself to decide whether the patient will benefit from some other treatment apart from the standard chemotherapy. Any other test you like to ask?
Sir, genetic markers.
Yes.
That's for like KRAS.
KRAS, whether it is wild type or mutated. Yes. Okay.
Wild type.
What else?
And
KRAS, MSI.
Yes, microsatellite microsatellite instability and sir, mismatch repair gene.
Yes.
And,
suppose there is a mutation in the MMR gene. What does that suggest? What does the patient have most likely? And which are the two genes which are most commonly involved?
So two genes the most commonly involved are the APC and the P53. Sir.
Mismatch repair. APC gene is not a mismatch repair. That is
mismatch repair backs and
no, they are the somatic mutations that are caused by the mutation in MMR. What are the MMR genes which are most commonly involved? You understand the difference between a germline mutation and a somatic mutation? The MMR genes which are mutated most commonly are the MLS1 and MSH2. MLH1 and MSH2. These are the ones which are most commonly involved.
Okay, these are difficult questions. Sort of.
Okay, fine. Okay.
Suppose you find single liver metastasis during surgery.
That is a good question. That is better.
You find single liver metastasis while doing surgery for right hemicolectomy. What is your strategy? What is the standard strategy? Single liver mets during surgery.
So metastatictomy should be done, sir.
Sir has asked you one question. Single liver met. No other information he has given you. You don't want any other information? Now I add the information. It is a single liver met involving the entire right lobe and involving the right branch of the portal vein also. You will go for metastasectomy?
No, sir.
In the same sitting. So then you have to ask, sir, that's a single liver met. Please mention the size of the liver met. Please mention the location, which segment it is involving.
Yeah.
There are many things involved. Single liver met in the caudate lobe. It is not so easy to remove the caudate lobe.
So again, you should read the liver metastasis management. It's a very important topic.
And if you want to do metastasectomy, will you do it with the tumor removal? Will you do it first and then do the colectomy, or will you do the colectomy first and then do the metastasectomy later?
You see, there are a lot of strategy now.
Sir, all the 3 ways it can be done, sir.
So which one will you do?
Depending.
I know there are 3 ways. I told you the 3 ways. Now tell me which one you will do.
It's a synchronous removal of the, if
You
it
will do
is
synchronous in all
resectable.
cases.
Not
But
in
the
all
albumin
cases.
was low. Albumin was low. What is the child puke criteria in this case? You've already said albumin is low. How much of FLR will you accept in this patient?
That,
While doing liver resection, you calculate the FLR.
yes.
Otherwise,
This patient
patient
is
liver
upfront.
failure. Huh?
This patient is upfront since he has come to you and you are going for surgery. So how much of FLR will you get? And then another patient went to medical oncologist. He had liver mets. The medical oncologist gave chemo. Now the liver metastasis is very small. There is single
Yes, sir.
met, very small. It is resectable. How much of FLR will you accept in that case? Is there any difference in the 2 cases? One is upfront, one is post chemotherapy.
You see, 30% is the minimal functional liver residue should be there for a patient
Yes, sir.
who is going upfront surgery. Patient on the background of cirrhosis, or as Dr. Ghosh said, patient has received chemotherapy with diminution of function as a whole, it should be 40%. Sir, it is right or 20 or 30?
Sir, 20 good centers may accept 25, but everyone will feel safer with 30, sir. For discussion purpose, yes, 25% also in a healthy liver. And post chemotherapy liver 30 and post cirrhotic 40%. But those are very, very borderline, sir. We would always prefer to have a lot more than that. At least I would. Otherwise, in our setup, the patient will die in the post-op period because of liver failure and sepsis.
Okay, Dr. Ghosh, we have a very nice discussion. You see, these are the basic things. We are not talking of very high-end things. These are the basic things one student should know how to approach a patient with good physical examination, and then investigation approach, and then the basic management. And don't give wild diagnosis, wild differential diagnosis. You are talking of a mass in this region and this background of melena. Primarily, it's a gut mass. So you confine to this basically gut mass. Okay. Thank you, Dr. Ghosh.
Okay, thank you, sir. Thank you very much.
Thank you, sir. Thank you, sir.
Professor Saha.
Yeah,
Professor
yes.
Saha.
Yes, Dr. Maiti.
Yes, I am making a question to both of you. When we are doing hemicolectomy, and you are mentioning, and also in the textbook it is written that this is the numbers of the lymph nodes which is to be studied. Okay, 12 or 14 like that, 15. But during operation, most of the time, the lymph nodes are so embedded in the mesenteric fat. During the operation, whether the surgeon will concentrate on the number, how many lymph nodes they are removing, or they will concentrate on the extent of surgery.
Dr. Maiti, if you do a good total mesocolon excision, you see the lymph nodes, some lymph nodes are on the wall of the colon, some lymph nodes along the vasa recti, some near the intermediate chain along the main trunk. So if you do a good total mesocolon excision with vessel ligation of the root, you need not confine for counting or see the lymph nodes during surgery. It automatically comes.
I'm just giving the importance to the message that the surgery should be adequate.
Yes.
And it is the part of the pathologist to find out how many lymph nodes the surgeon are excised, or the surgeon on the OT table, on the side table, he will pick up the lymph nodes. What is I want to know the opinion, comment from Dr. Ghosh. It is the duty of the surgeon to pick up the lymph nodes from the excised specimen, or he will tell the pathologist, I have done it, you identify the lymph nodes, and in the report he may say that only 5 lymph nodes are found. This may happen. What is your comment regarding this fact? Professor Ghosh, who will do the picking up of the lymph nodes from the specimen?
I think Dr. Ghosh has left.
So
but I can answer this
then.
question. I can answer this question, Dr. Ghosh. Maiti.
Yes.
If you have good pathology, dedicated pathologists, they do very good dissection because they are accustomed to dissecting these morbid specimens. If you see the report coming from TMH, if you see the report coming from one of the reputed lab in Kolkata, you will find they are doing fantastic dissection, sometimes dissecting 20, 26 lymph nodes. So you need a dedicated pathologist. I think It's the job of the pathologist to dissect the specimen and identify the lymph nodes. Or not
So,
all surgeons are conversant with the exact location of the lymph nodes. What
So
pathologists are
what
conversant.
should be the protocol? It is the surgeon's responsibility to
Protocol is
find out the
pathology.
lymph nodes.
I feel the pathologist will agree that this is the job of the pathologist to dissect the morbid specimen and dissect out the lymph nodes. That depends. You
Is
see,
it applicable? Is it applicable for all malignancy in all regions, or for particular, for example, breast? The surgeon is supposed to do the picking up of the lymph nodes from the specimen,
even
or it is
Dr.
organ
I
specific.
find if that all depends on the pathologist who you are entrusting on, because our medical college pathologists are too busy with so much of specimens, so they
And so
don't
that is the
devote that
question.
amount of time. I agree, but if you are with a dedicated pathologist, they do it fantastically. We have seen reports, which reports are very. But yes, you are right. There are a lot of reports which are coming that only 3 or 4 lymph nodes are identified. So that is because of pathologists not being serious in dissecting the morbid specimen. I think this should be the job of the pathologist. I agree that surgeon can do it, but then surgeon has to be very conversant. You see, I don't think a lot of surgeons are very conversant with the exact location of the nodes in a morbid specimen. You have done this study in medical college, I know, but that is we do not know the result. Pathologist versus you send the specimen to pathologist, to a dedicated pathologist,
The
not to somebody.
surgeon knows better the spread of the malignancy through the lymphatics, because he has studied the investigation. He's on the operation table. He's palpated. He has observed everything. Okay. Thank you. Actually, that is a question still left
Yes.
unanswered to me. I cannot get the exact answer in different occasion. I am asking the same question, but I think their standard protocol is not yet decided.
But if
Dr.
you see the
Professor
PMH
Monju
report now,
Banerjee is there and others are
you'll
there.
get astonished. You'll get astonished to find a report coming from pathology department of Tata Memorial Hospital, Mumbai. You see a report and read it. See the extent of the report they are giving. Thank you, Dr. Maiti.
Thank you.
Thank you very much.
Thank you, sir.
Thank you.